Finals SAQ70 ARDS. A. List the criteria for a diagnosis of ARDS. Based on the Berlin definition 2012, onset within 1 week of known clinical insult or new or worsening respiratory symptoms. Chest imaging shows bilateral opacities not fully explained by effusions, lobar or lung collapse or nodules, either on chest X-ray or CT scan. Respiratory failure is not fully explained by cardiac failure or fluid overload. Need objective assessment such as echocardiography to exclude hydrostatic edema if no risk factor present. Hypoxemia present with PEEP of 5 cmH2O or more, with a PaO2 to FiO2 ratio of 200 to 300 mmHg being mild ARDS, 100 to 200 being moderate ARDS, and less than 100 being severe ARDS. A correction factor should be applied if altitude is higher than 1000 meters. B. Which clinical indices are used to quantify oxygenation in ARDS? The oxygenation index is used to quantify oxygenation. OI is calculated as FiO2 times mean airway pressure divided by PaO2. OI of less than 25 indicates good outcome. OI 25 to 40 indicates more than 40% mortality, and OI of more than 40 consider ECMO. C. What tidal volume would you select for a patient that meets the criteria for ARDS using the ARDSNet protocol? First, calculate predicted body weight. Set initial tidal volume 8 mL per kg predicted body weight, PEEP at 5 cmH2O. Set lowest FiO2 that achieves SpO2 of 88 to 95%. Reduce tidal volume by 1 mL per kg every 2 hours until tidal volume is 6 mL per kg. Then measure P plateau. If P plat is more than 30 cmH2O, decrease tidal volume in 1 mL per kg increment until P plat is less than 30 or tidal volume 4 mL per kg. Monitor ABG for respiratory acidosis. If pH is 7.15 to 7.30, increase respiratory rate until pH more than 7.30 or RR equals 35 breaths per minute. If pH is less than 7.15, increase RR to 35 breaths per minute. And if pH is still less than 7.15, increase tidal volume in 1 mL per kg increments until pH is more than 7.15. D. What are the ventilatory and non-ventilatory measures that can be taken to improve oxygenation or prevent further deterioration in a patient with ARDS? Ventilatory measures. Aim to maintain adequate gas exchange until cellular damage resolves without causing further lung injury due to barotrauma, volutrauma, atelectrauma, biotrauma, and ergotrauma. Prevent stress of undamaged alveolar units. Most patients with ARDS require intubation and mechanical ventilation. The use of HFNC in patients with severe hypoxemia may prevent intubation. However, data on its use in patients with ARDS is lacking. PEEP helps to recruit atelectatic lung tissue and prevents the development of further atelectasis, which improves VQ matching, reduces hypoxemia, and limits the risk of atelectrauma. Tidal volume should be 6 mL per kg predicted body weight or less to limit volutrauma. Keep plateau pressure 30 cmH2O or less to limit barotrauma. Permissive hypercapnia. Accept PaO2 sufficient to adequately oxygenate tissues. Minimize driving pressure. An upper limit of 15 cmH2O is recommended. Consider prone positioning, which improves oxygenation, recruitment potential, reduces areas of alveolar overdistension, increases homogeneous aeration of the lung, reduces ventilatory-induced lung injury. Absolute contraindication for prone positioning includes unstable spine fractures. Relative contraindications includes pelvic fracture, facial trauma, facial surgery, raised ICP, hemodynamic instability, and massive hemoptysis. Evidence base. Interventions thus far shown to reduce ARDS mortality includes low tidal volume ventilation based on ARDSNet data. Mortality is reduced by 9%. Prone positioning based on the ProSiva multi-center RCT, whereby patients with severe ARDS are prone for at least 16 hours daily while employing lung protective ventilatory strategy. Prone position was associated with an improvement in mortality at day 28, 16 versus 33%, which persisted at day 90, 24 versus 41%. Unfortunately, complication rates are high, which included endotracheal tube obstruction, pressure sores, and loss of venous access. In the setting of COVID-19 ARDS, prone positioning has been safely and widely implemented for patients who are ventilated. The use of prone positioning has been extended to awake patients who are unintubated, but there are uncertainty with conflicting findings from recent trials. In the setting of ECMO, the role of prone positioning is uncertain. A systematic review and network meta-analysis in 2022 by Dianti et al. Has shown that in patients with moderate to severe ARDS, higher PEEP without lung recruitment maneuver is associated with a lower risk of death than lower PEEP, and a higher PEEP with prolonged lung recruitment maneuver strategy is associated with increased risk of death when compared with higher PEEP without lung recruitment. Low mechanical power is associated with lower mortality in ARDS, whereby power joules per minute equals 0.098 times tidal volume times respiratory rate times PEEP plus 0.5 times driving pressure plus peak pressure minus plateau pressure. In a retrospective analysis by Serpa et al. In 2018, the risk of death was increased with mechanical power greater than 17 joules per minute. Costa and colleagues found the component variables of mechanical power most predictive of mortality were driving pressure and respiratory rate. The findings from LIFE trial, which investigated personalized mechanical ventilation tailored to lung morphology in patients with ARDS, found that patients who received a ventilatory strategy misaligned with lung morphology increased mortality. Interventions with no proven survival benefit includes alveolar recruitment maneuvers, mode of ventilation, minimizing driving pressure, and extracorporeal carbon dioxide removal. Non-ventilatory measures includes treatment of the underlying cause, conservative fluid management, consideration of diuretics and hemodialysis in patients with fluid overload, physiotherapy to help remove secretions and improve gas exchange, early enteral feeding, ventilatory care bundle, such as 30 to 45 degrees head-up positioning, daily sedation hold, stress ulcer prophylaxis, and venous thromboembolism prophylaxis, ECMO in selected patients. The Caesar and EOLA RCTs concluded that ECMO reduces mortality in severe ARDS. ECMO was also associated with reduced mortality in patients with COVID-19 severe ARDS. Regarding neuromuscular blockade and sedation, in the PETAL study 2019, among patients with moderate to severe ARDS who were treated with a strategy involving a high PEEP, there was no significant difference in mortality at 90 days between patients who received an early and continuous cis-atracurium infusion and those who were treated with a usual care approach with lighter sedation targets. The ROSE study also showed no differences between groups in 90-day mortality. However, the ROSE study did not specifically evaluate ventilator desynchrony. The role of corticosteroids in ARDS management is a long-standing controversy. Using Bayesian methods, Saha and colleagues in 2022 showed the strength of evidence for corticosteroids in ARDS favors benefit and supports prioritization of future clinical trials investigating corticosteroids in patients with non-COVID-19 ARDS. Corticosteroids are the standard of care in patients with COVID-19 ARDS. Potential benefits of corticosteroids includes shorter duration of mechanical ventilation, improved gas exchange, shorter ICU stay, and it halts progression of pulmonary fibrosis. Based on a study by Kelfi CS et al. In 2018, patients with a hyperinflammatory phenotype ARDS treated with simvastatin were found to have significantly improved 28-day survival. The following drugs have no proven reduction in mortality yet, which includes inhaled prostaglandins, aspirin, surfactant, activated protein C, civalustat, beta-2 agonist, keratinocyte growth factor, and mesenchymal stromal cells. Chairman report, 57.3% pass rate. ARDS is acute hypoxemic respiratory failure with bilateral infiltrates on chest imaging, which is not fully explained by cardiac failure or fluid overload. The definition of ARDS have changed since the AECC criteria in 1994. The current Berlin criteria in 2012 included various changes such as defining the acuteness of onset. Opacities may be seen on CT as well as chest X-ray. ARDS can now be recognized as occurring alongside heart failure. Definition of hypoxemia requires PEEP of 5 at the time of measurement. And acute lung injury has been redefined as mild ARDS. Additional Q&A. What is acute respiratory failure? ARF is a syndrome in which the respiratory system fails in gas exchange in either oxygenation, carbon dioxide elimination, or both. Hypoxemic respiratory failure has PaO2 of less than 60 mmHg. Mechanisms include VQ mismatch, alveolar hypoventilation, shunt, diffusion limitation, and low FiO2. Assessment of AA gradient may help identify the underlying cause, whereby AA gradient equals alveolar partial pressure of oxygen minus arterial partial pressure of oxygen. Normal gradient is 4 plus H divided by 4. If AA gradient is normal or low, consider alveolar hypoventilation or low FiO2. If AA gradient is high, consider VQ mismatch, shunt, or diffusion impairment. Hypercapnic respiratory failure occurs when PaCO2 is more than 50 mmHg. Mechanisms include reduced central respiratory drive, abnormalities of the chest wall leading to restriction, airway abnormalities leading to increased dead space, increased work of breathing and fatigue, and neuromuscular diseases. What are the causes of ARDS? Causes may be classified as those causing indirect lung injury and direct lung injury. Causes of direct lung injury includes e-cigarettes and vaping, smoke inhalation, inhalational injury and near drowning, aspiration of gastric contents, pneumonia, pulmonary contusion, and ventilatory-induced lung injury. Causes of indirect lung injury includes neurogenic, ischemia reperfusion of the lung after transplantation or pulmonary endarterectomy, drug toxicity, transfusion-related acute lung injury, acute pancreatitis, non-pulmonary sepsis. Sepsis is the most common cause of ARDS. Severe traumatic injuries, fat embolism, pulmonary embolism, amniotic fluid embolism, and cardiopulmonary bypass. Some exposures can increase the likelihood of ARDS, such as alcohol use, cigarette smoking, exposure to ambient air pollutants, and genetic heterogeneity. Diabetes reduces the likelihood of ARDS. Explain the pathophysiology of ARDS. 3 phases includes exudative, fibroproliferative, and fibrotic phase. In the exudative phase, the precipitant triggers a cascade of dysregulated inflammation, which leads to injury of the endothelial and epithelial barriers of the lung, leading to accumulation of protein-rich pulmonary edema, surfactant dysfunction, and impaired gas exchange. In early ARDS, there is increased alveolar capillary permeability with neutrophil extravasation into the alveoli, leading to diffuse alveolar damage and loss of pulmonary compliance. This results in physiological derangements such as reduced compliance, increased dead space, increased shunting, and histological features of lung edema, inflammation, hyaline membranes, and alveolar hemorrhage. The fibroproliferative phase begins 1 to 2 weeks after the onset of ARDS. Patients who survive the initial disease have varying levels of residual pulmonary fibrosis. Cellular and molecular mechanisms of ARDS lead to characteristic physiological and clinical findings. Alveolar capillary barrier injury with interstitial and alveolar edema leads to reduced compliance and increased work of breathing. Diffuse alveolar filling leads to VQ mismatch and shunt, severe hypoxemia, and diffuse bilateral radiographic opacities. Surfactant inactivation and reduced production leads to end-expiratory alveolar collapse and favorable response to PEEP. Platelet and endothelial activation with lung microvascular thrombosis and obstruction or destruction of the lung vascular bed leads to increased dead space ventilation, pulmonary arterial hypertension, high-minute ventilation, hypercapnia, and right heart failure. Leak of lung inflammatory mediators into the systemic circulation leads to SIRS and multi-organ dysfunction. The severity of systemic and alveolar inflammation exists on a spectrum that varies considerably from patient to patient, contributing to heterogeneity. Treatable traits should be identified by biomarkers which align with underlying pathophysiological mechanisms, which could be targeted by specific interventions. What is multiple organ dysfunction syndrome? MODS is characterized by incremental physiological derangement in major organs such as the liver, gut, kidney, brain, CVS, or hematologic systems. It can vary from mild to irreversible organ failure. MODS is the single most important predictor of death in ARDS and is a much more common cause of death compared with refractory hypoxemia due to lung damage alone. Explain the pathways that restore homeostasis in the resolution of ARDS. In the resolution of inflammation, neutrophil apoptosis and clearance removes excess neutrophils from the airspace. Alveolar macrophage phenotypes shift from pro-inflammatory to anti-inflammatory. There is change of lung lymphocyte population to T regulatory cells, which orchestrate recovery. Chemokine and cytokine balance shift from pro-inflammatory to anti-inflammatory. The profile of lipid mediators in the airspace transitions from pro-inflammatory leukotrienes and prostaglandins to pro-resolving lipid mediators such as lipoxins and resolvins. This is followed with restoration of the alveolar capillary barrier, where lung epithelial growth factors trigger epithelial regeneration through replication and differentiation of lung stem cell populations. Restoration of lung epithelial integrity restores alveolar epithelial fluid transport, allowing clearance of alveolar edema. Balance of endothelial injury and repair mediators shift from pro-injury angiopoietin 2 dominant to pro-repair angiopoietin 1 dominant. There is restoration of lung endothelial and epithelial glycocalysis. Compare COVID-19 ARDS versus non-COVID-19 ARDS. Timing. Onset could be more than 7 days for COVID-19 ARDS. Thoracic imaging. There is overlapping thoracic CT findings during acute phase, but predominance of diffuse pattern with ground glass opacities in COVID-19 ARDS. Evidence of persistent interstitial lung disease is present in COVID-19 ARDS. Respiratory system mechanics are similar. Regarding biomarkers, lower total white cell count, reduced IL-6, and hyperinflammatory phenotype is less prevalent in COVID-19 ARDS. Regarding coagulation, higher platelet count, higher fibrinogen, lower PT, and lower APTT in COVID-19 ARDS is found. D-dimer is higher in non-COVID ARDS. Deep vein thrombosis is more common in COVID-19 ARDS. Various drugs are used to treat severe COVID-19, which includes corticosteroids, IL-6 receptor blockers, or baricitinib, which is a Janus kinase inhibitor. In non-COVID ARDS, there are no specific pharmacological agents which are recommended. Regarding adjunctive therapy, there is paucity of RCTs directly relevant to COVID-19 population. The use of recruitment maneuvers, prone position, and neuromuscular blockade are reported to be higher in COVID-19 ARDS. Regarding critical care outcomes, prolonged duration of ventilation in patients with COVID-19 has been reported, with similar mortalities. Regarding long-term outcomes, there are no difference in incidence of new disability at 6 months, and there is similar health-related quality of life, psychological, and cognitive function at 6 months. In survivors of COVID-19, an increased return to work at 6 months and 1 year has been reported. What are the guideline recommendations for management of ARDS? This table shows the guideline recommendations for 4 guidelines. The first is the Intensive Care Society and Faculty of Intensive Care Medicine Guideline. The second is the French Intensive Care Society Guideline. And the third the American Thoracic Society, European Society of Intensive Care Medicine, and Society of Critical Care Medicine guideline. The first three guidelines pertain to the non-COVID ARDS population, while the fourth guideline, the WHO Living Guideline, is specific for COVID-19 ARDS. For NIV, there are no specific recommendations for the first three guidelines. The WHO Living Guideline conditionally recommends NIV in mild ARDS. Lung protective ventilation is recommended in all guidelines. Prone positioning is recommended for moderate to severe ARDS. High PEEP is recommended for moderate to severe ARDS in all guidelines. Regarding driving pressure, the second guideline has no recommendation due to insufficient evidence. The third guideline, research recommendation. The fourth guideline recommends considering driving pressure as part of an individualized PEEP titration strategy. Regarding spontaneous ventilation, there are no recommendations in the first, second, and fourth guidelines. The third guideline recommends spontaneous ventilation in research. Recruitment maneuvers and HFOV are not recommended. ECMO is recommended in all guidelines. Extracorporeal carbon dioxide removal is recommended for research. Conservative fluid strategy is recommended in the first and fourth guidelines. Neuromuscular blockade is recommended in the first and second guidelines. The WHO Living Guideline does not routinely recommend neuromuscular blockade. Inhaled vasodilators are not recommended in the first guideline. The second guideline states that inhaled vasodilators can be used when hypoxemia persists despite lung protective ventilation and prone position, and before ECMO. Corticosteroids is recommended in COVID-19 ARDS, but it is recommended in research in non-COVID ARDS. There are no recommendations for other pharmacological agents in non-COVID ARDS. However, in COVID ARDS, IL-6 receptor blockers such as tocilizumab or sarilumab or baricitinib, which is a Janus kinase inhibitor, is a strong recommendation. Monoclonal antibodies such as sacirivimab and imdevimab is a conditional recommendation for patients who are seronegative. What are the contraindications and benefits of permissive hypercapnia? Clinical trials show that hypercapnia is safe for most patients up to arterial PCO2 of 60 to 70 mmHg and arterial pH of 7.2. Contraindications for permissive hypercapnia includes raised ICP, intracranial hemorrhage, sickle cell disease, severe left or right-sided ventricular failure, pulmonary hypertension, salicylate or sodium channel blocker overdose, pregnancy, etc. Benefits of permissive hypercapnia includes attenuation of ventilator-associated lung injury, myocardial protection, attenuation of reperfusion brain injury, delay of hepatocyte cell death, anti-inflammatory effects, and modification of key components of inflammatory response. Describe the principles of ROSE fluid resuscitation conceptual model. The four dynamic phases of fluid therapy according to the ROSE concept is depicted here, where R stands for resuscitation, life-saving resuscitation phase with focus on patient rescue, and early adequate fluid management, for example 30 ml per kg over 1 hour according to surviving sepsis guideline, or fluid challenge or bolus of 4 ml per kg given in 5 to 10 minutes. Trigger to start IV fluids is shock. The resuscitation phase occurs during the first hit or initial insult, which may be sepsis, severe acute pancreatitis, burns, trauma, etc. Fluid balance is positive. The goal is to correct shock. Time frame is in minutes. Various monitoring tools of volume status are used, such as arterial line, CVP, PPV, SVV, uncalibrated cardiac output monitoring, etc. This is followed by the optimization phase, with focus on organ rescue or maintenance and avoiding fluid overload, i.e. fluid creep. Aim for neutral fluid balance. Triggers to stop IV fluids includes hemodynamic unresponsiveness. The optimization phase occurs during the second hit, which is ischemia reperfusion. The goal is to maintain tissue perfusion. Time frame is in hours. This is followed by the stabilization phase, with focus on organ support or homeostasis. Late conservative fluid management is defined as 2 consecutive negative fluid balance within the first week after initial insult. Triggers to start fluid removal includes fluid accumulation syndrome or global increased permeability syndrome. The stabilization phase occurs during the second hit or ischemia reperfusion phase. Fluid balance is neutral or negative. The goal is to aim for 0 or negative fluid balance. Time frame is in days. Next is the evacuation phase, which focuses on organ recovery and resolving fluid overload with active late goal-directed fluid removal and negative fluid balance. Triggers to stop fluid removal is hypoperfusion. Fluid balance progresses from negative to neutral. Goals includes mobilization of fluid accumulation and maintenance of tissue perfusion. Time frame is days to weeks. The third hit occurs during the evacuation phase, which involves global increased permeability syndrome. The fourth hit, which is hypoperfusion, may follow the evacuation phase. This diagram lists the various adverse effects of fluid overload and accumulation, which may occur at the abdominal wall, kidneys, liver, gastrointestinal system, cardiovascular, respiratory, and central nervous systems. What is the mortality and sequelae associated with ARDS? Regarding mortality, when ARDS was first described in 1967, the mortality rate was approximately 58%. The overall mortality rate of patients with ARDS over the past several decades have been approximately 43%. Mortality rate of ARDS has progressively declined over the last decade to approximately 30%, but is still 41 to 45% in those aged between 65 and 84 years old, and about 60% in patients over the age of 85 years old. Clinical factors that predict a higher mortality in ARDS includes male sex, African American race, advanced age, alcohol abuse, malignancy, liver disease, chronic steroid use, HIV infection, and ARDS secondary to sepsis or aspiration. The leading cause of death in ARDS is multi-organ dysfunction syndrome. Regarding the sequelae of ARDS, limitations in lung function are typically minimal based on mean values of pulmonary function after 5 years. There is a wide spectrum from moderate to no impairment of forced vital capacity or diffusing capacity. The majority of physical impairment is due to reduced exercise capacity and musculoskeletal weakness. There is high prevalence of cognitive deficits, depression, and anxiety, as well as reduced rate of return to work. All of these negatively impacts the quality of life among survivors. These are my references. Thank you.